Okay, well, thank you very much for the invitation. I really appreciate it. So, for the disclosures for my 7 seconds, my disclosure is that I added another video to that other video. So, just for comparison, I promise I'll keep it, under the 7 minutes or 10 minutes that we have. So, case one, this patient basically is. Let's see here. Okay, so this is a 45-year-old lady that had a laparoscopic gastric bypass. She presented with colicky abdominal pain. She has no acute distress when she was in the ER. She had a benign abdominal exam and had normal vital signs, normal white count, and normal lactic acid. Her CAT scan showed these, what appears to be a small bowel obstruction. However, when I got the phone call around like midnight, the patient looks very stable. You have cases in the morning. How about, we can explore her as the first case around 6 a.m. or so. And then what came to my mind is always that picture that we always show about that, patient with a dead bowel. I'm like, not sure. So I decided to explore her. And then as soon as we got in, we started running the bowel. And this was basically a very simple, straightforward case. It was a simple band that has created this closed loop bowel obstruction. And because it's overnight, the staff did not know what to open. They opened everything they had, so I had a sonicision available, because that answered the question. I got many about that question on the Facebook group. Why did you use a sonicision? I'm like, it was just open there, so I just used it. And basically, it's straightforward. It's a very simple, satisfying case. You just divide that band, and the question remains after that, what to do with that loop of bowel. Looked very angry, but obviously did not look ischemic, and this is a laparoscopic case, so I would have just, stopped there, not do anything more, and just observe the patient. However, we did use ICG. I thought that was a simple, easy thing to do, so we give the patient few cc's of ICG. You can already see the bowel starting to kind of, pink up a little bit and that congestion go away, but you can see clearly with the ICG that the bowel was viable. Let me just fast forward through this. And that's that. So for the sake of comparison, I present another case, which is case 2. This is a different story. A 53-year-old lady, laparoscopic bypass in 2019. However, she had an open splenectomy with a large splenic cyst. She also had an X-lab for a perforated marginal ulcer, but per history, it was very complicated. She had a wound vac. She had ended up with a very large incisional hernia, loss of abdominal domain, and all this was done in an outside hospital. She presented to another facility with abdominal pain and paired their report on their CAT scan that I was able to access, but not the images. There was swirling of mesenteric vessels, and there was infiltration in the small bowel, in the vessels, and the bowel. The radiologist was concerned of ischemic bowel. However, that patient was observed overnight and was discharged next day, and this is a discharge summary. There was some denial in the case, saying there's no pneumatosis, there's no wall thickening, abdominal pain resolved. In the conclusion of the discharge summary, she may have had a small bowel valvulus, and that spontaneously resolved. So, of course, 2 weeks later, she ended up in our institution, and this is her CAT scan. Of course, she had that big, large abdominal hernia with bowel kind of sitting up there, but she had that classic swirling sign. And I look at the abdomen, and I'm like, I realize the reason why they did not want to operate on the patient there. But of course, this is her second presentation with a CAT scan like this. There's no way you can ignore it. And I decided, as always, to just try to go in laparoscopically. And to my surprise, you get in, and any experienced bariatric surgeon will see that chyle ascites, all over the abdomen. And surprisingly, there are no adhesions in the abdomen. And that's that big hernia. It's completely empty. There's nothing. It's probably one of the easiest internal hernias I've ever done. It was a very straightforward, simple release of all the small bowel, just pull, and the entire thing just came out very easily. And I think the reason why she probably lasted for like almost 2 months, maybe from the beginning of her symptoms, is that JJ defect was so big. It wasn't, very, very tight, but clearly that was her, that mesenteric swirling on the CAT scan was not, just a simple whatever small bowel valvulus. It was a true internal hernia. And you can see that clearly the mesenteric defect here. And then we basically just closed that. And we also closed Peterson's space that we found open. And that took care of that. So in conclusion, I think denial is your worst enemy. You can always come up with an excuse why not to operate, correct? And it's clearly in that discharge summary from the resident. It was from the the surgeon that saw that patient. And then convenience should never factor into your decision-making. It did try to factor in my decision-making that night. I was like, it's only a few hours, I can get it in the morning, but I bet you if she was discharged the same day in the morning. She would have probably been there for a few more days with a bowel resection if I waited for a few more hours. And then don't miss the boat. I always hear the thing about the pulse is normal, there's no tachycardia, there's no white count, there's no that. If you see those things, you already missed the boat, correct? There's already a bowel ischemia, a dead bowel. I mean, otherwise there won't be tachycardia, correct? So don't wait for that. You gotta act up very early. And then a negative laparoscopy is a great outcome. If you go in, there's nothing there, well, that's what you want. You don't wanna, that's a great outcome. And so, and please, for God's sake, close your mesenteric defects. This is 2019. The bypass was done in 2019. Why are the mesenteric defects not closed? And then with the bypass patients, I always say, I can think of, I don't know how many scenarios you can think of where you don't explore a bowel obstruction with a gastric bypass patient. I can't think of anything. So if you have a bowel obstruction with a bypass patient, please explore. And that's that, yeah. Thank you.
Thank you.